It's an extensive introduction and quite appreciated.
Thank you.
So, what I'm going to do today to you is just take you through my approach towards cerebrovascular disease. And that means that we as neurosurgeons, if appropriately trained, have the ability to treat cerebrovascular disease through any and all means necessary. And my point is that these two ways of us dealing with disease are truly complementary, and that's the way they should be adopted. So here are my disclosures. So there are limitations to conventional microneurosurgery. You're unable to get a 360-degree view of the anatomy. It's impossible. You only have your surgical approach. Unfortunately, when you clip aneurysms, there is still a risk of recurrence. It's lower than endovascular treatment, but it's not zero. Same thing goes with AVMs too. The cure rates with surgery are higher, but they're not complete. And unfortunately, the problem with a lot of our acute emergencies with cerebrovascular disease is that we can't shift the patient from here to there, from the angio suite to the OR, from the OR to the angio suite, without incurring additional risk. And so, we are starting to also appreciate that the gold standard for cerebrovascular cure remains currently digital subtraction angiography. And I think indocyanine green has made a big difference in terms of surgical confirmation of clipping, but it's not the gold standard yet. And so the hybrid OR, the concept is that you have your microsurgical equipment, you have your microscope, you have your navigation, indocyanine green, you have anesthesia, you have neuromonitoring, but then you also have monoplanar or biplanar angiography. So you have everything in one spot. And so here are examples of the rooms in multiple labs. Ours is a little bit different. This is ours. So we have patient position for a craniotomy. We have radiolucent head clamp. We have our microscope, and we have angio, and you can sort of see microscope here, angio here, so you can potentially do things almost simultaneously. Although almost always, we never do them exactly simultaneously. They're a little bit staccato because where you want to have the microscope is typically where you want to have the X-ray tube. So you need to move them back and forth. The value of a hybrid approach is that just starting out with diagnostic angiography, I always do my vascular cases in a hybrid room, even if I'm not planning to do an endovascular intervention, just because doing a diagnostic angiogram and confirming the result before I start closing the head is extremely beneficial. And that way, especially with AVMs, you've confirmed that there's nothing left before you leave the OR. And so rather than do the typical, you get a CT, then you go to ICU, then the OR, then the ICU, then CT, then angio, you can do all of that at one time at the same time in a hybrid setup. And so there are lots of options: enhanced localization of vascular lesions, integration of neuronavigation, confirmation of the clip ligation, or resection of an AVM, or obliteration of a fistula. So it really is quite useful. So let's start by looking at some case examples. Intraop angiography in the angio suite. It's a complex ACOM aneurysm, 47-year-old, incidental. There it is. You can sort of see the aneurysm right there. It's an ACOM aneurysm. And here's a 3D, and you sort of see this ugly, large aneurysm. And so I'll just take you through this video. Nothing fancy about Sylvian fissure dissection. I am a strong believer in microsurgical sort of sharp technique. So here we are putting a temporary on the A1. And once we have it, look, we can see the aneurysm. Looks pretty clear. There is the big sac, and we dissect it off. And we think we can put a clip on. Right? Looks pretty straightforward. We have exposed our entire aneurysm. There we go. Put a little clip. Okay, we are done. Take the temporary off. Look at that. Large recurrence. And what I initially thought was A2 was aneurysm. And now I put the second one on, a temporary clip on, and now I'm going to find what I thought was there was A2 was actually dissection, was part of the aneurysm. And so with that established, now I'm going to put a fenestrated one to address this. Pulling it back, make sure I get the whole thing. That looks better. Confirm we got the whole thing. Take the temporary off. Now it's gone. And so it's not because I didn't understand. I had rotation, I had everything, but you're in the OR, you've got just one skewed view. So that's a perfect case example of where intraoperative angiography allowed me to reposition the clip, prevented a rupture, prevented return to the OR, and I was able to address this comprehensively at the same time. So next is, I think this is the same one I just showed. Yeah. So here's a 22-year-old female with an AVM, episode of seizure activity, no neurologic deficit, big, ugly AVM. So trying to go for this directly microsurgically, it's almost a Spetzler-Martin 4 to 5, and eloquent cortex. It didn't really have any significant deep venous drainage, although there's some going towards, you can see a little bit of delayed function. This is what I got at the end of 5 embolizations. And I can tell you in this day and age, maybe if I was doing this, I would consider a transvenous approach for this, given its singular vein. But in this instance, I went ahead and took this patient to the operating room. And this is where we are actually going in and resecting the AVM. And as we go ahead, we are finishing up. We've got the whole AVM dissected, leaving the vein alone. There's the last little bit. You're taking the vein out, and we do. This is the end result. And we do an angiogram, and we have complete resection. And so in this instance, there was a little bit of residual left right there, right here. So we took the patient back. It looks good, but we saw this and we took the patient, not patient back. We just went back in and found it. We actually used X-ray to confirm where this was in the cavity, just using X-ray. And so we knew based on AP and lateral where it was. So we localized with AP and lateral exactly where it is. And then that's the part where we went, because you can see with onyx, it's sometimes very hard to know where something is left and where something is not. So this is that small residual I'm talking about right here at the very anterior medial edge. And the patient did very well, had a little SMA. And so that's the value of surgery. Moving on, something a little bit different. So this is a patient who presented to me with an aneurysm which was getting larger, left MCA fusiform aneurysm. And it kept getting bigger and bigger and bigger and bigger. This is vessel wall imaging. You can see enhancement right there. And this is what it looked like. So endovascularly, if I was going to treat it, I would have a problem, because which branch do I flow divert? And it's left side. And so in this instance, what I did was I ended up using, excuse me one second, my family is waking up right now, so they're making a lot of noise. So give me 1 second. It is Saturday morning in Buffalo, and so everybody's waking up. So this is what I did, just to make sure people understand. So I did a radial artery to M2 and M2 to M2 and a distal clip. So I recreated a bifurcation through the radial artery and occluded distally and completely excluded the aneurysm. So, and the patient did well. So sometimes and when I do a bypass, I always do angiography intra-op to make sure that there's no evidence of any residual disease. Another approach for hybrid is access for endovascular therapy. So here's a 53-year-old who presents with a left occipital arteriovenous fistula. This is what the fistula looks like. You can see this venous drainage right here. And look at this middle meningeal artery. It's perfect for access, but look at this tortuosity. This tortuosity is so severe that I know there's no catheter I can make to go from here to there. It's impossible. And unless I get into this venous pouch, I'm not going to, embolization is going to be no good. And if I have to do surgery, I'll have to skeletonize the entire transverse sinus. So it's a big operation. It's not a single draining vein, which can be simply clipped. And so given this degree of tortuosity, these coils, I decided, well, why do endovascular from here? Why don't I do a small craniotomy right here and put a catheter right in here and go from here? So that's exactly what I did. I did a small craniotomy. Look at this. Just enough to expose using navigation. This is the middle meningeal artery through the bone. I didn't even have to expose or take a flap off. I just drilled down using navigation exactly where middle meningeal was. I introduced a catheter using just forceps into the vein. There I am, hybrid suite. I do an angiogram, confirm I'm in the right place. There you can see my microcatheter that is brought in from here and embolized it and cured it. And so that is, and cured the patient. Another interesting access strategy was this young woman that I had been treating for. I actually didn't start in 2013. I started in 2006. I only became full professor in 2013. So I've been in Buffalo a long time. And so I've been treating her forever and ever. She came in when I first joined the practice, 27-year-old. Now she's 30-something, 40-something. And she had embolization, transarterial, and then 3 rounds of gamma knife. And this is the AVM. It's insular and frontal opercular. This is what it used to be, ganglionic, massive. After 3 rounds of gamma, this is what is left. There is no direct arterial supply to this. It's all PL collaterals, ACA and MCA PL collaterals, and they drain through this massive labet. And this drains into transverse sigmoid sinus. So I thought maybe I can go through, from a transarterial access standpoint, stop flow on the arterial side with a balloon, and then use a large bore Onyx compatible catheter, put a guide into the vein of Lebet, and put 2 catheters there and use one to coil and the other to inject Onyx transvenously. That was the plan. And do all of this during transvenous pacing to drop the blood pressure to as low as possible, and allow us to do all of this at the same time so we have complete flow control. And so I tried that. I got everything all set up. Unfortunately, with this venous stenosis, I could not get access. I tried for hours and I could not get access into the vein. So what do? Well, let's switch approach. Let's do an open approach. So in this instance, I went back to the hybrid suite. You can see I'm there. I did a small, I was prepared for a full incision, but I just did a linear incision over the zygoma. You can see I have arterial access, I have venous access, it's all labeled. And there's the dura. And there is a picture of me holding the catheter with my gerals, my forceps, and introducing it into the vein. So here is a little video of that. So this is that large labet that you saw that was draining the AVM. So I'm exposing the vein, and I thought this was a great opportunity for me to actually look at flow. So what I did was I actually measured flow to see how much blood was going through the vein, to see the value of putting up a balloon and putting up so this is the baseline flow. It's 120 milliliters of per minute. And then when I start pacing, it drops to 40 milliliters because the blood pressure is in the 30s. It's transient. You can't do venous pacing for more than 45 seconds or so because of cardiac ischemia. But then when I inflate the balloon on top of pacing, it drops to 2 milliliters per minute. Complete flow arrest. So it completely deflates the vascular system, so optimizes the conditions for transvenous embolization. So this is an angiogram after we were in position. There you will see in a second, there is the AVM right there draining into this large vein. And this is how it is. I am putting a catheter, my catheter tip is there. Balloon is up in the ACA and the MCA. There's a clip on the vein. And I'm just injecting Onyx, and see, this is live, and you can see how it's going to different regions and really curing the AVM literally in seconds. And so highly effective where you're combining open and endovascular approach. And this is the ECA angiogram, and then the patient actually did exceptionally well. And this is the final post-embolization run, where we have no external feeders, and this is the final run with no AVM. Completely cured, and the patient did exceptionally well. He's a school teacher and continues to teach. Then the next category is rescuing. One procedure doesn't do well, so the other one helps. So endovascular rescue of microsurgery. So here's a 54-year-old presents with altered mental status and GCS of 3, Hunt has 5, large hemorrhage, temporal lobe. And angiogram suggests PCOM aneurysm with thrombus in it, right there. So because of the hemorrhage, and we went to the hybrid suite. And in the hybrid suite, we went, clipped the aneurysm. I don't have a video of that, but I do the angiogram, and this is what I see. Post-clipping. And so we have an occlusion. So we see some decent flow across the midline, but you can see it's delayed. So we go back. We can't go do TPA. We just did a craniotomy. We got to do mechanical thrombectomy or go back to the OR. But then what are we going to do back in the OR? Are we going to open the carotid in a swollen, angry brain? So we do mechanical thrombectomy. First, we go up with that aspiration catheter. And you can see this is, we try to suck the clot out. It opens up a little bit, but there's still a lot of clot sitting in here. And there now you can see after the first pass, there's thrombus sitting inside the artery, but at least you got some flow right there. So we then take another look. 2 minutes later, looks like we might be done. It's closed back up again. So this time around, we do a second pass. It looks like maybe we have narrowed the artery or there's thrombus. There's the clip blades. You can see it. It didn't look compressed at all during surgery. but that second pass doesn't work. It occludes again right there. So the third time, I pull out a stent retriever. I didn't want to do a stent retriever across a freshly clipped, ruptured aneurysm, but that's what we do. And this is the result. Wide patency of the artery with no residual. Patient did very, very well and recovered 1 month later, almost intact. And this is a CAT scan 4 months afterwards. There's the clip, there's a hematoma that was removed at the same time, and the aneurysm is well treated. So I think what happened in this instance was just going back, showing you what the original aneurysm looked like. If you look at this, there's thrombus sitting in here. So while I was dissecting the neck, I probably caused some of this thrombus to come into the lumen. And then when I clipped it, that got stuck and pinched there. And that's what was causing the occlusion. But that's the value of being a hybrid person. You can go back and forth between the endovascular realm or otherwise. So, but it's not only one directional. Microsurgery comes to the rescue of endovascular all the time as well. Here's an example of a giant or large ACOM aneurysm, a subarachnoid hemorrhage, that was originally treated elsewhere with coiling. It recurred and then was treated again outside place with stent-assisted coiling with an Elvis stent placed in the ipsilateral A2 and additional coiling, and it kept recurring. So then a patient was referred to me, and my initial attempt was to try to go through this Elvis into that, but the coils and the anatomy did not allow me to make this into a Y stent. I could not. And it kept growing. So here is an interhemispheric approach where I'm going to expose both the ACAs. There you can see the ACAs have been exposed. And then I'm opening up the two pericallosal arteries right here. And then we're just suturing these together. And we do the inside out, the bottom limb, and then we come up top and we do the top limb. And there we are starting to do the top part. And once it's all done, then we go ahead and slowly start releasing clips. And when we are releasing clips, look at this. This clip is still on. You can see this branch flowing both sides. And I'm going to take this clip off, and you'll see it flows in both directions immediately. There you go. So this is a well-functioning bypass. And then I just clip the aneurysm. I coil shut the ACA at the same time in the hybrid suite. And so this is now complete cured. 1 year later, there's my bypass. It's widely patent. And there you can see right there. And so this really shows you that there's no evidence of any residual aneurysm, and it's well treated. And so that is, an example of rescue. Moving forward, true endovascular and microsurgical hybrid, where you're doing it all at the same time. Here's a case of a ruptured MC aneurysm with a large sylvian clot, a 41-year-old, and extensor posturing. Look at this large hemorrhage. And in this instance, what do you do? Well, we need to look at that patient's herniating. And so you need to do a decompressive cranie at the same time. But then trying to find the MC aneurysm in such an instance with a swollen brain is going to be hard. It'll just destroy the brain. So what do? You go to the OR, you do a decompressive cranie immediately, open the dura, and then switch to endovascular and go interruptive coiling. And we get simultaneous groin access and decompressive cranie at the same time. Dura open first, aneurysm coil second, clot removed third. And that allows you, there it is. There's the aneurysm, that's the coiling, and patient recovered with significant right hemispheric dysfunction, MRS3. But that really allowed us Do not delay one thing versus the other. We do all at the same time. Problem remains, though, that there are challenges with the hybrid ORUs. We are fighting with other disciplines, cost effectiveness issue, case volume. Multiple disciplines want the hybrid suite. But here's the fact that unless you use it regularly, you're never going to use it. And so that's what the point that I've made, that I really like to do all vascular cases, microsurgical cases in the hybrid suite. And with that, I'll stop and I'll take some questions, and I thank you very much for your attention.
Thank you, Professor, very much. It was a wonderful lecture with amazing cases. Thank you for sharing your insights and experience. I see one question in the chat, but before that, I would like to give a floor to the neurosurgeon from Turkey, Professor Faik Özveren, who has extensive experience in both endovascular and microsurgery. So please.
Professor Faik Özveren?
Yes, his microphone
Yes,
is
I am here. I am here. Thank you very much, Dr. Siddiqui, for this nice presentation. Actually, you are doing very nice operations. For the endovascular and our common neurosurgical approaches as a neurosurgeon, actually, it is good to have two abilities at the same time. But in my opinion, specialization on the only one side may be much more better, because both facilities are not suitable in everywhere. It is one reason, and another reason, if you are doing one job too much always and always, your skill is increasing. That's why it seems to better to approach one side for me. It is my idea.
Yeah. And so this is what you're saying is what has been said for time immemorial. But let's look at my practice. What do I do as a neurosurgeon? I do petroclival meningiomas, acoustics, olfactory groove meningiomas. What does that have to do with clipping an aneurysm? Not much. But honestly, the techniques that I use for dissection of the tumor of the nerves in an acoustic is exactly the same kind of techniques I use to uncover the adhesions for clipping an aneurysm. My microsurgical handling of the suction and micro scissors is identical in almost all my cases. So much so that it's the same technique if I'm taking out a schwannoma from the sciatic nerve. So microsurgical techniques are ubiquitously applicable across broad brace. That's one thing. The second is that as technology becomes more available, there is a strong push towards going for less invasive strategies if the outcomes are similar. Obviously, if the outcomes are massively different, then there's no question. But if the outcomes are similar, it's easy. I'll give you an example of that, which is I developed a technology which is now broadly available in the United States. It's called a surgiscope, which is a 15 millimeter tube, 15 millimeter, designed to do microsurgery through a tube. And we routinely use it for transventricular lesion, deep-seated tumors, etc. You can do fluorescence, you can do microsurgery, you can use 2 hands. You could do the same thing by a big craniotomy, but less invasive is an attractive means of taking care of things. And so in that regard, what happens when you only are a one-trick pony is that you develop biases which impede your ability to provide proper care. Because if you can only do one thing and somebody else can only, there's always this conflict. There's always this conflict. With me, I never have a conflict. I'm taking care of the patient and I'm trying to strategize the best way for each one. And sometimes it's this, sometimes it's that. Many times it is both. And the final thing I would say is that as this transition to less invasive occurs, microsurgical techniques become less frequent. And that means is that I end up doing a lot more microsurgery because I get everybody, rather than centers where you only have one person doing microsurgery and everybody else is doing endovascular. They lose the skill set. So I have a very high volume. I do about 2 to 3 bypasses a month. That's my volume. And I can compare my results to anybody. And I do about 800-900 endovascular cases a year. I can still do a bypass. I don't think I have a problem with that. So, and those numbers are as high as anywhere else. So I think as neurosurgeons, we are much more talented than you give yourself credit. We can do endovascular and we can do microsurgery. It's understanding, I think it makes my understanding of vascular disease much better because I have, oh, this is what it looks like from the inside. This is what it looks like from the outside.
Yes.
Thank you, Professor. I think that was a perfect explanation. Now I would like to give a word to the doctor, chief of department in Western Georgian Medical Center, neurosurgeon Jakob Tsertsvadze. If possible, we can unmute him.
If you want.
Yeah, I can read his question because yeah.
You can.
Thank you. Thank you, Professor, for your interesting presentation. I just living from Germany. I was as a observership in Chapeau department in Essen. Also, I am a dual trained neurosurgeon, and it's great to listen to your presentation. Is it possible to visit in your department as the international neurosurgeon, as an observer?
Absolutely. We have international observers every week.
Wow.
Probably not quite as many as my dear friend Renee, but we always have some international physicians. So absolutely write to me, and I'd be happy to arrange that. And that's true for anybody and everybody. You can come in, spend some time, and see what we do.
Thank you. Thank you. I appreciate. Thank you. Good luck.
Thank you.
Thank you.
Thank you.
And now I will read questions from the chat part. Fatih Yakar, neuroendovascular neurosurgery department of Pamukkale University, Denizli, Turkey, is writing. Thank you for excellent presentation, dear professor. For pediatric patients, which dual antiplatelet regimen should we prefer when we perform flow diverter stent deployment? And second question, when you perform microsurgery to rescue endovascular procedures, how do you manage the antiplatelet therapy that patient use because of stent?
Good. A great question. So the therapy for adults and pediatric patients is the same, but you can make it weight-based for kids. And you can use PRU blood testing to really confirm efficacy. I have stopped using Plavix for any intracranial case. So no more clopidogrel because there's too much resistance and variability there. I almost always use either ticagrelor or prasugrel. My preference is ticagrelor precisely because we can stop it and reverse the functionality within 12 to 24 hours. And then you can do what you need to do. Like, for example, somebody's got a stent and they are on aspirin and Brilinta, and now you need to put in a shunt and take out the EVD. You stop the Brilinta, you give it a week or two so you have some degree of endothelialization and cover. Then you stop the Brilinta, you transfuse platelets while you're doing the actual procedure. And then you, after the completion of the procedure, you resume your Brilinta. And so it's not that complicated.
Thank you very much. Next is Dr. Ayman, neurosurgery resident from Kazakhstan. She writes, thank you very much for the presentation. In acute subarachnoid hemorrhage, do you prefer endovascular or microsurgical approach? And how do you deal with a vasospasm?
Great question. So I strongly prefer endovascular for ruptured aneurysms because you're not manipulating an angry brain. I like my brain surgery to be like the ones I showed you. No blood in the fissure, micro scissors, everything is beautiful. The brain's not swollen, it's ideally relaxed, and you can go ahead and treat it. For ruptured aneurysms, unless there's a large mass lesion, or there is really no good endovascular cure, so it's a pyramidal, very shallow aneurysm, those are the kinds where I'll still do microsurgery. I would say 10, 15% of the time, I'm going to the OR for ruptured aneurysms. For unruptured aneurysms, I still go to the OR about 25, 30% of cases for unruptured. But for ruptured, it's less likely that I do that. In terms of spasm, I'm very aggressive with spasm, and I almost always, I start with intraarterial verapamil, vasodilator during the procedure. And if I'm going to treat the patient, I'll almost always follow up with either a stent retriever associated plasty or a balloon plasty. And when I use a balloon plasty, I always use coronary balloons because they have a much more specific profile. They're not going to over dilate. So I never, ever use the neuro balloons such as the Scepter or Eclipse or any of those for vasospasm because they can cause vessel rupture. I always use coronary nylon balloons.
Thank you, Professor, for your response. I don't see any more new questions, so I'm going to use this time to ask my question. I was wondering, how do you envision the role of hybrid neurosurgery in the upcoming decade or so, and how it's going to change the training of young neurosurgeons, and what kind of innovations are you expecting from the future?
Yeah, I think it's a very, very dynamic field. We are still in, the way I'll think about this is we are still in the plumbing phase of our profession. If it's bleeding or can bleed, we clip it or take it out or glue it. And if it's plugged, like a stroke, then you unplug it. That's all we do. Plug and unplug in fancy ways, but that's what we do. I'll start off by talking about where this field is going. Blood vessels, both arteries and veins, are highways to the brain, to the end organ. Just like highways to the heart, highways to the kidney, highways to the legs, highways to the brain. And what that means is that you can take that route to deliver therapies, which would be very, very hard to do. So for example, we all are used to treating hydrocephalus with ventriculoperitoneal shunting, right? I do a couple a week, I still do. But now I've treated a few patients with transvenous shunting. So you go into the inferior petrosal sinus, make a hole, and put a one-way valve tube from the CP angle cistern to the jugular vein, this long. And it cures communicating hydrocephalus, not obstructive hydrocephalus, communicating hydrocephalus. Another case, we have done a few cases now, is that we go in, put in a stent with chips to record and stimulate the brain and connect it to an outside brain-computer interface so that a patient who's quadriplegic can now use their iPhone and type by just thinking and turn their lights on and off. That's the future. That's the future. Now, how much is going to be micro versus endo? I think that's going to continue to shift, but I can't foresee a time when there will be no micro. That's impossible. So I think there'll always be complementary. And I really feel that compared to interventional neurologists or interventional neuroradiologists, neurosurgeons have a unique opportunity and ability to be able to treat any which way. And so they should really make sure that they have a good understanding of all methodologies.
Thank you so much. I think it was a beautiful allegory with the highways. Thank you so much. Dr. Faik Özveren is asking about transvenous hydrocephalus device. If you could elaborate more on that details.
Sure, absolutely. Go ahead.
May I ask a question?
Yes.
I think Dr. Adel Malik has written about this topic, and they have introduced in a case in the literature. I had read that paper, but as a person who has anatomical study on the skull base, their approach seemed to be very complicated, and I had written a letter to editor to their paper. So that area is very complicated place. Yes.
Yeah. So let me put it this way. And the procedure I did was with Adel Malik's device. They created a company called Ceravasc, and we are one of the principal sites where we are using that technology now for a very initial first-in-man study. But the way I think about this is that it is proof of concept. Proof of concept. This is a procedure where there is no incision anywhere. There is no hole in the head anywhere. There's no belly opening anywhere. We go in through the groin, and I agree with you. There are lots of complexities that need to be addressed. But what a brilliant idea to cure communicating hydrocephalus. And there are lots of little things that happen that we don't realize. Part of the reason shunts are a problem is because they're a very long system. Lots of points, lots of joints, lots of angles, valve, this, that, and the other. When you have a device which is this long and small, it almost never breaks. It can't. The physics is in favor of it not breaking. The flow rates are much better. It doesn't get obstructed like shunts do. You know, so there's so many unique value propositions. I agree with you. The technology is still very early on, but you know, technology takes years to develop. But what a great idea to be able to now treat hydrocephalus. Another example, and they're going to do this in the future, is delivering drugs directly to the brain. You know, compared to putting other systems, this is a wonderful way to introduce new technologies to the brain. So there's a lot that's happening in the space.
Wonderful.
Professor,
On that approach, one point I had difficulty to understand. That is the anterior pontine membrane is extending from in the clivus from above to below, and there is subdural space at the clivus in addition to subarachnoid space. So my question was this one: how you will be able to pass through the arachnoid membrane?
It's a needle. It goes right through. It goes right through from the dural sinus, and you need to have 5 millimeters of clearance. You check on the preoperative MR, and you do cone beam CT to confirm that you are in the right place to make sure that you are in smack dab in the middle of the CP cistern. That's part of the technology issues where currently, if you have an AICA loop or a PICA loop in that region, you can't do that case because you got to be mindful. But it's a sharp needle that goes right through. There's no issue penetrating. And then you do a cone beam CT to confirm that you're in the right place.
Okay, thank you.
Thank you so much.
We have a couple of minutes left, and I would like for Bektaş Açıkgöz, professor from Antalya, to make a comment or ask a question.
Thank you, Professor, for sharing your great work with us. Thank you very much. Since you have limited time, may I ask your experience on the stroke centers? You have great experience, I know.
Yes. So, well, we were amongst the very first stroke centers in the United States. Buffalo was really at the forefront of the first trials, including the intra-arterial trials with 2B3 inhibitors and et cetera, before we had mechanical devices. So we have been long-standing supporters of the concept of getting as many sites for stroke as possible. For aneurysms, we don't need a lot of sites. We need experts. But for stroke, we need to get the patient treated as quickly as possible. And the stroke technologies are nowhere as complex as treating an AVM or an aneurysm. You know, treating an AVM or an aneurysm is a hard thing, microsurgically and endovascularly, no question. Stroke should not be a hard thing. Stroke should be a very straightforward thing. So I'm a strong believer in getting as many people to help out with stroke so the patient can get a thrombectomy to the closest place to their home. Unfortunately, it's a hard thing to do for a vast majority of areas, including in New York, where I live, in Western New York. We have a very large rural population which lives hours away from stroke centers. And so maybe there's an opportunity there for robotic or telestroke. That is something we are working on to try to figure out where, you know, you could have one center in İzmir and that can treat patients through robots in a 500-mile radius, which would never get to İzmir in time to get a procedure done. So I think there's a lot that is happening there. I feel almost that the level of expertise required for ischemic stroke should be lowered while maintaining hemorrhagic disease. So almost like two pathways. Just because stroke is such a time-sensitive, high-volume place, I think, for example, in our place, you know, I used to do every other call. Then we hired a third person. Now we have a fifth person. So finally, life is starting to get a little bit easier for me in terms of call. Because when you're on stroke call, you're guaranteed you're going to come in the middle of the night once or twice a week, at least 3 times a week. It's not unusual. When you have an AVM aneurysm rupture, almost always, unless there's a big hematoma, you got to go to the OR, which is not that common. You can put it on for the first case next morning. And so it's a very different way to treat diseases. So when it comes to stroke centers, I think we need some evolution in our thinking.
Thank you very much. Congratulations. Thank you.
Thank you.
Thank you very much. Now, last question from me. What about the learning curve of becoming a dually trained neurosurgeon, hybrid neurosurgeon?
Great question. Great question. So I can tell you that, and I think Dr. Asvaran also mentioned this, and he's absolutely right. You know, we are in a surgical trade, whether you do endovascular or you do open. And a surgical trade depends on volume. The more you do, the better you get. It's very simple, no question. Now, the training curve could be steep, where you could quickly acquire skills, or could be shallow, where you take a while. I think the initial skills are steep for both procedures, but to become an expert is a much more shallower curve, and therefore volume is important. So the question becomes, how do you supplement volume? Endovascular, you typically end up getting more volume, so I think it's less of an issue there. But we make our fellows practice on 3D printed models all the time. So when we have a difficult case, we 3D print so that they can go and try to do it. So when I'm doing it, then they can do it afterwards, and I don't need to watch them and spend 2 hours seeing them struggle. But they can get better by practice. That's endovascular. Microsurgery, we create a lot of rabbit aneurysms, which means taking 2 millimeter vessels, 1.5 millimeter vessels, and sewing them together in different configurations and sewing a venous pouch on top and such. So those microsurgical skills apply and translate into the clinical realm. The other thing is, while vascular disease is declining, brain tumors are still very common. So I strongly recommend keeping a tumor operations part of your microsurgical skill set, because I think you'll probably do 3 tumor cases for each vascular case. And so getting really good with your tools in microsurgery during tumor cases also help making sure that you are improving your efficiency and proficiency for vascular.
Great, thank you very much for your response. And Dr. Özveren wanted to add about CT angiography if we have 5 more minutes. Yeah.
Professor Özveren, I want to say that one of our residents or our young neurosurgeons, one of them at least, will visit Professor Adnan Siddiqui if he is accepted.
Of course, happily.
I would like to add a point to your good presentation. When I do open surgery to an aneurysm case, I always go to laboratory CT unit, and at that point I do the 3D image by myself and put the same position of the patient when I on the Mayfield head holder. During that image, I can understand which sides of the aneurysm can I see, which vessels are not cannot be seen, and I memorize that view. So it is very helping. But as you said, DSA is the gold one.
Yeah, and this is also a common point that is made, is the CT angiography supplants diagnostic angiography. Possibly for aneurysms, MCA bifurcation, which you're going to clip, it's a large aneurysm, you can understand exactly what you described. But we do angiography for a much broader cohort of patients. Sulcal subarachnoid that comes in, non-traumatic, or an acute subdural that comes in non-traumatic, or an intracerebral hematoma in a 37-year-old person, non-traumatic. When you look at them, you look at the CTA. CTA is very good for circle of Willis, proximal vessels, but its efficiency, its proficiency declines tremendously beyond it. Like, we have the most advanced CT scanner on the planet. It's a 640 slice CT, which gives us almost DSA quality images. But even on that, the moment you go beyond M2, it starts becoming useless. So I completely agree with you. I think for large proximal vessels, MCA bifurcations, you can rotate the 3D. Well, I do exactly what you're describing, and I save those images with actual rotational 3D. Same thing. I do the exact same thing, and I put those images on large frame in front of my window in the operating room. So I can always look at the microscope, look at the picture, go back and forth, say, that's where that is. So I do the same thing.
Thank you.
Thank you very much. I don't see any more questions in the chat part. I want Kamil Hoca, do you want to comment maybe?
No, I want to thank again to Professor Adnan Siddiqui, and I hope to see him in real life.
Thank you very
forward to
much.
Thank you very much, everybody. Have a good
Thank
evening.
you, audience, for your collaboration. Thank you.
Have a nice flight.
Thank you. Thank you.